So the today's talk is the management of brain metastasis. We know it's the most common intracranial tumor in adults, and over the period since 1960, we are treating the brain metastasis with the radiation. So it is the primary brain tumor seen 10:1 number of cases, and the brain mets develop in 20 to 40% of the cancer patients, and which has significant impact in the patient's life, in the overall survival as well as cognitive function and neurological symptoms. But over the period since in 1960, we used to give the whole brain radiations, and since then we have seen the spectrum of evolution in treating the brain metastasis. Because the over the period we have developed the number of systemic therapies, targeted therapies. There is a evolution in the radiation and the surgical techniques. So, and we are also focusing on the patient's quality of life as the survival is increasing. So we have seen the spectrum from radiosurgery, if not radiosurgery, then whole brain radiation with a hippocampal avoidance, use of mementing with hippocampal avoidance whole brain radiation, and a very much selective use of whole brain radiation therapy, and the use of systemic therapies. So we all aware that the investigation is always MRI brain, the contrast enhanced MRI with T1 pre and post. We do with T2 weighted sequence, and we also do some additional sequences to differentiate from non-neoplastic and other neoplastic processes. Definitely, with the help of MRI and the target therapies, we are able to
Yes,
detect the, yes,
we are not able to see the slides. Can you make full
no,
screen? And yeah, yes, now slide is changing, but can you make it a full screen?
now,
No, it's not full screen.
Yeah, you can see.
yes,
Uh,
now you can see.
no, it's still. Yeah,
The investigation?
yes, investigations we can see, but not
No.
full slide. But maybe if it is not happening,
Now,
continue.
Right side, lower down, there is a corner, there is a mark that it
yeah,
can.
I have done that, sir. I have done. It's a full screen. I have done that already.
I think there is some connection problem today because of the weather. So
Okay,
I
okay,
think
okay,
let's
but
continue.
we are able to see the slides. Don't worry. Continue, please continue. Dr. Vikas?
Yes, 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 sir. I will continue.
Yes,
Yes.
please continue. Yeah.
So we all know the how we identify the brain metastasis from non-neoplastic or the other neoplastic etiology. The just like that, they have a typical location of a gray white matter junction, significant perineal edema. There may be central necrosis with solid cystic lesion, significant disproportionate perineal edema. So these are the a characteristic of the brain metastasis. But at the end, we have evolved over the period that clinical decision making is not only about the there is a brain metastasis and we have to treat the whole brain radiotherapy or the surgery. But now there are a number of factors which we consider, because in previously we used to see the recursive analysis, which is only depends on extracranial lesion or the performance status of the patient. But nowadays we also see what is the oncogene or molecular profile of the patient, and there's a multidisciplinary discussion among the neurosurgeons, molecular pathologists, the radiation oncologist, the medical oncologist, to decide the decision making, even in the case of the brain metastasis. So it depends on number and size of the brain mets, performance status of the patient, how is the extracranial disease, what is the neurological deficits of the patient, and we enter all these things. We discuss with the patient how much about the local control, chances of the post radiation, about the chances of risk of radiation necrosis, chances of developing other brain metastasis post local radiation therapy, and the follow-up imaging and salvage treatment options. So all we know that the few we have come now RPA to GPA, that is graded prognostic assessment
चर्चा अटेंड
scores.
करूंगी अपन थोड़ा वेळ मूवी बघू ठीक आहे ठीक आहे ना
तेवढं काय वेळ
Hello.
लागला शिमला यायला
त्याच्यातून तो सीएनजी मित्रांसोबत खेळत असेल तो आजचे टॉपिक तसं पण असे काही खूप माझ्यासाठी हे नाहीये
Uh, can
राम रवी
Hello. Yeah.
अरे मेरे को क्लास नहीं बा
So GPA score. So GPS score is basically the disease related score mainly for the common metastasis which we see, basically breast, lung, colorectal diseases, where and melanomas, where the brain metastasis is very much common. So in such cases, basically we see the GPS score. So the lower the score, the better is the survival that we see from time since initiation of the brain metastasis treatment. So it is GPS score is mainly used for the cases where newly diagnosed brain metastasis, and it will help us to guide the treatment. This is very standard treatment. All the symptomatic brain mets, we know patient if has the symptoms of rest internal pressure, we definitely go ahead with the giving the steroids or the mannitol if required, radiation or surgery. But if the patient don't have symptom, we directly start with the treatment regarding the brain metastasis. There is a study from the TMH also which that prophylactic antiseizure medications are unnecessary in patients who have not had seizures. Now we'll come to our topic mainly, that evolution of brain mets treatment strategies. So from the whole brain radiation, we have moved to the radiosurgeries. So there are a number of publications regarding the radiosurgery. Then we have gone from the hippocampus awareness, the whole brain radiation from the Vinay Gondi and the Brown et al. Group. And further, we have gone to systemic therapies and the base supportive care also.
Vikas, sorry to interrupt. The slides don't seem to be moving. We are still in investigation slide.
Oh,
Yeah. Now is the next slide. Yes. Evolution of brain mets. Okay. Go ahead, please.
So
Thank you.
evolution of brain mets. So from whole brain radiation, we have gone to radiosurgery, and then hippocampus avoidance whole brain radiation, hippocampus avoidance with memantine and base supportive care as well as systemic therapies. So we'll come to the most interesting topic, that is what are the indications of radiosurgery for the intact brain metastasis. So if these are the all astro guidelines which are developed over the period since almost 20 years, they have studied number of trials they have seen with number of clinical scenarios, with the number of histologies and number of different radiation doses, number of radiation techniques they have studied, and they have recommended these guidelines. So if you see the patient with a good performance status with up to 4 intact brain metastases which are less than 2 centimeter in diameter, we can definitely go with a radiosurgery, that is single fraction radiation, to a dose of 20 to 24 gray. If the brain metastasis is more than 2 centimeter and less than 3 centimeter diameter, and we are able to achieve the normal brain tissue constraints, then we can go with a single fraction of 18 gray in single fraction. But if we are not able to achieve the normal dose constraints of the brain, we can go with a fractionated radiosurgery, that is the dose of around 27 gray in 3 fractions, which is definitely give the more tumor control, as well as try to reduce the chances of radiation necrosis. But for patient with a tumor size is more than metastasis size is more than 3 centimeter, we will prefer multifraction SRS in view of radiation necrosis and the tumor control. So the dose is 27 grain 3 fraction, or 30 grain 5 fraction, or 25 grain 5 fractions. But we should mind that multidisciplinary discussion with neurosurgeon is must while considering the larger metastasis, because some patient definitely require surgical resection if it is causing the mass effect irrespective of the tumor size. So if the tumor size is more than 4 centimeter, so definitely surgery is conditionally recommended, and if not feasible, we prefer to do fractionated radiosurgery than a single fraction radiosurgery. We should understand that there is a limited evidence that SRS for tumor size more than 6 centimeter, because it is not able to achieve the normal tissue, normal brain constraint, as well as increase the chances of radiation necrosis, as well as patient develop the radiation toxicity in terms of acute toxicity as well. For patient with a symptomatic brain mets who are candidate for local therapy like radiosurgery or surgery, the CNS active systemic therapy upfront is recommended. But if the patient is asymptomatic for brain metastasis and patient has CNS active systemic therapy, that means there are targeted therapies or immunotherapies which are crossing the blood-brain barrier. So in such cases, we prefer the systemic therapy than the local therapy if the patient is asymptomatic. But we should discuss with the patients and the relatives regarding the chances of developing the brain metastasis, the progression of brain mets, and they require close follow-up neuro-oncological surveillance and the availability of salvage therapies. So this is the what we follow at our center. The planning prerequisite, we make a mask or there is a frameless and frame-based radio surgeries we do. We do the MRI, planning MRI for each patient, which is a thin slice around 1 millimeter, which is 3D FSPGR sequence with a double contrast sometime. And we do the planning CT with a thin slice to detect for the, which is helpful to detect for the planning purpose for because the planning system where the, if the thin slices CT scan is there, then the planning is much better. So after doing the planning scan, we do the contour based on the guidelines. If it is a intact brain metastasis, contrast enhancing brain mets, just give a 2 millimeter margin and we do the planning. But if it is a post-op cavity, then we have to take entire tract, dural attachments. If any microscopic extension, we are expecting that also we include to avoid the chances of leptomeningeal disease. So, and we do the give some margin of around 2 millimeter based on the immobilization and 6D couch correction. 6D means there is a longitudinal as well as robot rotational corrections we do for the patient to minimize the error as well as to minimize the normal tissue radiation. So this is all we do, and the evaluation is done, and we take the patient for radiation. So this is what we use at our center. We make a mask with this. You can see this is jaw immobilization also, and this is the mask. At our center, we use the cones for the around smaller tumors like 5 millimeter to 2.5 centimeter, which is very give conformal dose distribution and contextually constrain the dose to only to the tumor and spare the normal brain around it. In some center, we also use the cyber knife or gamma knife, which is based on collimeters, so which is also gives equal results. So this is the, after making a plan, we do the treatment delivery after doing the patient specific quality assurance. We do the, we have the cone beam CT scan. So in which after patient lie down, we take the CT, we match with the target volume. If there is an error, we do correction. After delivering the fraction to the patient, again, we take a CT scan to check is there any error during the fraction itself. Again, we do the treatment. So there is a interfraction as well as interfraction. We do the image guidance to be precise for the treatment. So what adverse effect we can see with the SRS? We definitely see less memory disturbance because hippocampus area is spared. Acute effects we can see in 1 to 2% cases in terms of vomiting. If the location is near to the motor area, sometimes motor neuropathy in 1 to 2% cases. Late effects are mainly radiation necrosis, which we see, and extremely rare cases, radiation associated secondary malignancies. So this is our institute. We have done around stereotactic cases in last 3 to 4 years, around 125 cases, and most of the patients are the brain metastasis. The around 25 cases we have done the radiosurgery, and around 15 to 20 cases we have done the fractionated radiation. And the most of the patients, if you see, are from the breast, lung, or renal carcinomas. So what are the indications for whole brain radiation with the intact brain metastasis? You see the for patients with a favorable prognosis and in which we are not able to do the radiosurgery or the surgery, we are go ahead with a 30 grain 10 fractions because the prognosis is favorable, so we are expecting the long-term survival. And if possible, if the tumor is not in the vicinity of the hippocampus, we are able to do the whole brain radiation with a hippocampal avoidance. Along with the whole brain and hippocampal avoidance, we are using the NMDA receptor antagonist, which are able to protect the memory function of the hippocampus peripherally and which acts as a neuroprotective agent. So memantine is also recommended. We are not using it for many patients, but definitely is recommended in the guidelines. But for patient with a poor prognosis, we are definitely has the option of best supportive care, and there is a good evidence to show that the patients, we are definitely counsel the patients and caregivers that there is an option of best supportive care versus whole brain radiation. If you want to give whole brain radiation, it can be the single fraction or 20 grain 5 fractions. So this is the study from the Vinay Gondi from Wisconsin, which has shown that the hippocampus avoidance is possible in whole brain radiation, where the tumor is not located in the 5 millimeter vicinity of the hippocampus, in the bilateral hippocampi. So this is the RTOG 933 study, which has shown that it is possible that avoid the hippocampus and do the we can avoid the neurocognitions in the cases of the whole brain radiation. The similar group has also done the hippocampal radiation along with the memantine, and they have shown that the mean dose to hippocampus is around 9 gray and the max dose is around 15 gray, and they have shown that the neurocognitive failures were less in a patient in which the memantine with hippocampal avoidance is done. The neurocognition function are better even at the 1 year. So this is the study which has done were done with under guidance of Dr. Jalali in TMH, where we have shown that the higher end techniques, high precision technique, has the potential to spare the hippocampus in a benign and low grade brain tumors. So, but still today also we are in many patients we are using the whole brain radiation because for patients we found with a extensive extracranial disease, sometime unfavorable biologies and multiple brain mets. So since 1954, we know that we are using the whole brain radiation, and still we have seen that partial, complete or partial clinical response is seen in 60 to 90% of symptomatic patients. And the duration of improvement is around 10 to 12 weeks, which is sustained for many months to years. So indications of surgery, because this topic is non-surgical management, so this is only one slide which I included for the brain met size. So only if you see the surgery we recommend for the larger metastasis when there is a midline shift or the patient has no extracranial disease, control extracranial disease. There is a DICE, we are doubtful about the histology, or we are doubtful that whether the lesion in the brain is a tuberculosis or other primary. That time definitely we ask the patient to undergo the surgery. So if you see, there is a strong recommendation that even if you do surgery for brain metastasis and if there is a favorable biology and there is a limited additional brain mets, we can do radiosurgery over the whole brain radiation to preserve the neurocognitive function and patient reported quality of life. So this is a level 1 evidence. If you see, these are two study. One is done by Dr. Mahajan from MD Anderson, and this is another study from Paul Brown. So one has compared the SRS versus observation, and other has compared the SRS versus whole brain RT. And if you both study, if you find combines together, if you really see that if you do the whole brain radiation, there is a decline in neurocognitive function as well as SRS boost to cavity associated with a better local control compared to observation. So all patients ideally should undergo post-op SRS boost to brain metastatic site. And now this is the slide which is, you can see the systemic therapy. Now it's a wonderful role. Yeah, if the patient with CA lung comes with a brain metastasis, initially we used to give the whole brain radiation, even if it is asymptomatic. But now we know there are many drugs which crosses the blood-brain barrier, and they can definitely control the cranial disease much better way. So there are drugs like osimertinib, or in melanoma drugs like the nivolumab, ipilimumab, or the anti-HER2 therapies, which are the most common cancers which shows the brain metastasis. So in asymptomatic cases, definitely we can go ahead with the systemic therapies. And if you can see these charts, at least for first 2 years, we can definitely control the disease with systemic therapy. Later on, we can have CNS directed radiation or the surgery, whatever is based on the patient symptom and the performance status. So we can delay these therapies based on the systemic therapy and what is the molecular profile of the patient. So this is the other best supportive care is also the option which we see on the ASTRO recommendation. So some patients definitely we can go only with the steroids with or without whole brain radiation. This is, you can see, this is almost there is no difference in overall survival even if you observe the patients, and the data is around 538 patients. So some patient with a poor performance status, instead of going with any CNS directed therapies for the brain mets, we can just go ahead with the steroid and giving the symptomatic care than doing any active intervention. And the similar study was extrapolated in TMH by Dr. JP Agrawal, and who has developed one prediction model based on the patient age, gender, his EGFR status, type of metastasis, external disease. And we have shown that there is a high risk group which is matching with the observation group of the quad study. So definitely in our setup also, we can use this prediction model to know which patient should undergo observation and which patient should go for the whole brain radiation therapy. So the message from the today's presentations I want to give is we should have the patient-centered multidisciplinary evaluation and discussion prior to initiation of treatment with the patient's relatives and the multidisciplinary team. SRS for patient with limited brain mets with a good performance status. Multidisciplinary discussion with neurosurgery to consider surgical resection for all tumors causing mass effect and tumor greater than 4 centimeter. For patients with symptomatic brain mets, upfront local therapy is preferred. For asymptomatic brain metastasis or CNS active systemic therapy, local therapy may be safely deferred. For resected brain met, post-op SRS is must. Whole brain radiotherapy with hippocampal avoidance and memantine is recommended. For patients with poor prognosis, early introduction of palliative care for symptom management and care supports are recommended. If brain mets are asymptomatic or symptoms controlled with steroids, omission of WBRT should be considered. Thank you. Thank you for patience listening.
Thank you, Dr. Vikas.
Thank you, Dr. Before going forward, Sarang,
Yes, sir.
having two major events in the next month. I would
Yes,
like to mention that in our today's presentation because both the things are going to happen in our Maharashtra only.
yes,
So
sir.
the first thing is the Craniovertebral Junction and Spine Society Week from 2nd to 6th August in Mumbai, of course hosted by our great Dr. Atul Goyal sir. And we would like to have participation from all of the dignitaries. Second is on the
नहीं अभी बात करो अभी अभी बोलो फोन पे बोलो तुम में से क्या इश्यू है बोलो
sir. Hello. Hello. Hello.
हाँ, sir.
Second is from 9th to 11th August. That is, we are having a neurotrauma conference at Pune. Organizing president Dr. Patkar sir, and of course Sarang is the secretary, and we all are really awaiting for this great events to happen in a great manner. And about the discussion of today's topics, we will take it at the end of the presentation. I think that Dr. Tyagi has also joined, so we will continue with our presentations. The next talk is by Dr. Rakesh Jalali, sir. Hello.
Yes, I'm there.
Yes, sir. Sir, please, sir, you have your own great legacy, and definitely we will be benefited by your topic of your so much of clinical work on molecular markers in clinical practice for common brain tumors. We neurosurgeons generally they generally are not very much aware of these factors. That is definitely molecular markers in clinical practice and how they are going to help us with for the benefit of the patients. So hand over to Dr. Jalali, sir.
Thank you, Dr. Giri. I hope you are able to see my screen, everyone.
Definitely full screen,
Yes,
sir.
yes, thank you. So I'd like to begin by expressing my gratitude to Dr. Giri, who initially called me, and I cannot say no. You know, I have spent 18 years in Mumbai before I was in Chennai. So I have very strong relationship with Maharashtra, and it's great pleasure virtually to see a lot of my colleagues and ex-friends. Dr. Patkar is there, Dr. Kishore Chaudhary, Dr. Goyal, of course, and many others I can see, like Dr. Dindorkar. So I have been asked to speak on molecular markers, and as was rightly mentioned, it can be a little intimidating because really the neuro-oncology, especially in the last 7, 8 years, have taken quite a bit of turn around the molecular and detailed neuropathology. And we have listened to these talks many times. We are very fortunate in our country that we have outstanding neuropathologists, right from Dr. Chitra Sarkar to Vani Santosh to Geeta Chako and Sridhar and many others. And yet, as a clinician, both from neurosurgeon but also neuro-oncologists like myself, we still do not understand it fully, and it's continuous learning process. In the next few minutes, I'll try to break it down, and I thought 2021 classification was a good one in some ways. It has tried to make it simplified, what earlier 2016 classification showed us. But at the same time, some of the basic things that we must incorporate in our clinical practice and try to make it as clinically relevant as possible. So general, but yet significant changes in the 21 classifications are very simple things. First of all, There are 14 newly recognized types. We were very used to seeing this kind of a Roman numerals 1, 2, 3, 4, and all of us in our clinical practice have suffered. Sometimes the report shows 2 bar 4 or 3 bar 4, and you always wonder whether it is 3 or 4. So the WHO, the neuropathology community thought that it is better to have Arabic numerals. They have still remained the tumor taxonomy, but they have created that layered integrated diagnosis, which is histomorphology, which is still the fulcrum and very important. Some basic IHC markers, which are relatively easy to available in most of the laboratories. And then, of course, you go to the next generation sequencing and detailed molecular markers and DNA methylation. There are some unique specific changes. The division of gliomas has been very broadly divided into adult types and pediatric types. The 2016 was a little bit overwhelming. I'm not saying it is still not overwhelming, but it is simplified. And the most important point is glioblastoma is IDH wild type. I think everyone knows about IDH, and even there is IDH mutant, you never call it glioblastoma, even if they have microvascular proliferation, palisading necrosis that you are associated with GBM. But if they are IDH positive, we call them IDH mutant or grade 4 astrocytomas, such that the neurosurgical community and neuro-oncology community looks at it slightly differently. The interesting thing is so therefore the adult diffuse gliomas are actually only 3 types now. Very simple. Astrocytoma IDH mutant can be grade 2, grade 3, grade 4. There is no grade 1 tumor which will have IDH mutation. Oligodendroglioma, there is no grade 1, there is no grade 4. It is grade 2 or grade 3. 100% oligodendrogliomas are IDH mutant, and 100% oligodendrogliomas are 1p19q co-deleted. Both the deletions are positive. If there is only one deletion, you cannot call it oligodendroglioma. Both the deletions have to be there, and IDH, of course, is 100% mutant. And if IDH is wild type, you just cannot call it astrocytoma mutant or oligo. It has to be a glioblastoma. Even if it is a high-grade oligodendroglioma, we call it only grade 3. Now, pediatric type is slightly more complicated. We don't need to discuss too much, but essentially they are in what we call MAP kinase pathway related. We can discuss a little bit more in detail. And pediatric type diffuse high-grade gliomas, most of the pediatric gliomas are circumscribed tumors, which we know. And the diffuse high-grade gliomas are essentially very simple to understand. They rarely have IDH mutation. They will either have histone mutation or they will have BRAF/MAP kinase mutation, and we'll discuss a little bit as we proceed. 2 important things are circumscribed tumors are just pointed out here. Pylocytic astrocytoma, everyone knows there is nothing called pylomyxoid anymore. There is a subset of patients which may not be grade 1. We know them. They are typically teenagers and young adults, posterior fossa pyloid features. They have high-grade features. We call them high-grade astrocytoma, the pyloid feature. So it's grade 3. So it's grade 1 or grade 3, nothing grade 2. SEGA is still grade 1. Pleomorphic xanthoastrocytoma is not grade 1. Minimum is grade 2, and it can be grade 3. And chordite and astroblastoma is a new entity. It has to be characterized by the unique markers called MN1 altered. And suddenly in the last year or so, we are all seeing increased incidence of astroblastomas. I hope in your practice too. And no grade has been assigned as yet because we still do not understand their full implications of their prognosis. But last point I want to make is, what is interesting is that adults can sometimes have a pediatric type diffuse low-grade glioma, and pediatrics patients can sometimes have an adult type diffuse low-grade glioma. It's not only related to the age, it is also the morphology and what is the final diagnosis depending upon moleculars you have. And I'll just show you 2 or 3 cases just to keep everyone's interest. Young lady, you can see this left frontal tumor. In fact, she was operated upon in Italy. She was holidaying there, and they thought it was actually an arachnoid cyst. She came back, was reoperated upon, looked like an oligo-looking cells. ATRX is always retained. ATRX is a very simple IHC marker, costs only 1,000 rupees or so, but so beautiful marker. Because if ATRX is lost, it is almost always an IDH mutant. Astrocytoma kind of rules out oligo and GBM, except if it is grade 4 astro. Grade 4 astro ATRX will be lost. Oligodendroglioma, never ATRX will be lost. If somebody says ATRX is lost and somebody says it is oligo, something is wrong. Either ATRX is not or it is not oligo. So very simple, IDH mutant, ATRX retained. You should try to do 1p19q if it is possible. Slightly more expensive because you need FISH technique, which is about 8,000 to 15,000. Rest of the molecular markers you can manage in about 3 to 4,000 rupees. Why anaplastic oligo, even grade 3, is important is because the median survival of a grade 3 oligo, well operated upon, sometimes can be deep seated towards the corpus callosum. They can be towards the cingulate gyrus, little hard to, you can do a biopsy or even a partial excision. Do the adjuvant radiation temozolomide. The median survival is now 17 to 18 years. It's been extremely good tumor to have, but provided you diagnose it correctly. Now, a very important paper came last year in New England Journal of Medicine because we discovered a drug against IDH. Now, IDH is a gliomagenesis gene. It is actually a driver mutant. It actually creates, it is the main gene which makes oligos and astrocytoma. So there's a drug which is called vorasidenib, and there's another drug called ivosidenib. We don't need to discuss too much. This trial was actually not the best trial. It was basically observation versus the drug in a small, sometimes we observe these tumors, all of us do, especially young patients, less than about 3 to 4 centimeters, very little residual in a little bit eloquent cortex near the insula towards the motor cortex, speech, and so on and so forth. And then you give them vorasidenib, so the survival was slightly better, the PFS, not so much in OS. But as a proof of principle, it's very exciting because now we have a drug against a mutation. And there are so many trials now going on which are trying to utilize the drug in a very meaningful and very intelligent way, including in grade 3, grade 4 tumors, which are not so great tumors, but which have IDH mutation because it can block the mutation and hopefully make an impact in their outcomes. There are several issues. Which tumor to do? It's very expensive as yet. It's not available in India. The variant of ivosidenib is available because we use in myeloma. I have already 3 patients on that drug, but we will discuss as we go along. I do want to bring out everyone's attention, and we have very, all of you are associated with MRIs. Sometimes even a simple MRI will help you, and I'm a strong believer of imaging biomarker, a very simple test of T2 flare evaluation, which most of us, we always do. So if there is no, mismatch between a T2 and a flare, it is most likely an oligodendroglioma. It's basically an IDH mutant tumor. If there is a mismatch, they invariably are astrocytomas. And for example, there is, this case you can see, and there's an island of hyperperfusion. It was a young doctor from UK who we operated upon, Dr. Rupesh, my colleague. You can see a classic mismatch. This is the T2 and this is the flare. Flare is so hypo intense, and this is so hyper intense. And there is so mismatch. Very rarely this will be oligo. It is likely to be a very astrocytoma, and therefore sometimes, you don't need the full molecular markers, and sometimes helps in decision making. If it's an oligo, perhaps in this location, close to the eloquent cortex, even if it was awake craniopathy with monitoring, you can perhaps leave the tumor left behind in astrocytoma. You can be slightly more aggressive, although quality of life and preservation of neurological function, a young doctor, is absolute paramount. So, but these are some of the things which are very exciting. There's a lot of focus on radiomics or radiogenomics. And in my group in Tata Memorial, and now also in my Proton Cancer Center, in a series of papers, our Indian data is also very strong, looking at different aspects of medulloblastomas, in gliomas. We just published in Nature scientific reports last year from our group in Apollo Proton Cancer Center, a beautiful radiogenomic paper on ASL versus APT. It's a perfusion marker, an MRI, and in 95% of the tumors, you can actually diagnose pilocytic astrocytomas only on MRI, and also is a BRAF fusion. And sometimes even pilocytics can be difficult, and all of us know that. So this is a useful imaging marker. My prediction is in the next 8 to 10 years, there will be a lot of AI, there will be a lot of platforms on MRI which will use radiomics and radiogenomic data. So it's better to know a little bit about it. And you have to have more integration with your neuroradiology colleagues, which we already are having both preoperatively and postoperatively, but also on the adjuvant therapy, as well as from a radiogenomic point of view. Now, we always used to think PXA is a very simple tumor. We always used to speak in the same breath as, say, for example, a DNET or a pilocytic, and all of us have burnt our fingers that all of them are not so great. Therefore, I'm happy that WHO says at least the minimum is grade 2. Our group, again, in TMH has published series of papers on, including in PXAs, and we showed. And the interesting thing is 80% of PXAs will have a mutation which is seen only on a simple IHC and which does not cause so much, and it is called BRAF mutation, BRAF V600 mutation, and that's very interesting. But what is also interesting, which is a case 2, it's a glioblastoma patient actually, 2016, and that did relatively well. For 4 years, she was doing very well. So you wonder what is happening there. She was actually reoperated upon, and again, she has spent 4 years. And because it was what is now called epithelioid glioblastoma, a small percentage of the patients, typically in young patients, sometimes slightly older also, typically cortical located, present invariably with a hemorrhage, you can operate upon them very well because being cortical location. And then if they have a BRAF V600 mutation, which most of them have, there are 2 targeted therapies available, dafrabolib and trametinib. And this patient has been on those drugs for 4 years, in spite of having a histopathologically confirmed glioblastoma. Even if it is an epithelioid GBM, she has done extremely well. And we have some more patients like this as well. So there is a lot of focus. There is one paper in the Lancet, what is called ROAR study, whichever high-grade gliomas, the gangliogliomas, PXAs, epithelioid GBMs who have BRAF V600 mutation. And in pediatric population, difficult PXAs and also pilostic astrocytomas, which have BRAF fusion. Pilostics do not have mutation, only 10% have mutation. They have BRAF fusion at RNA level. And there you can use the dual therapy or MEK inhibitors, we call them trametinib, and you can avoid surgery, you can avoid radiation, you can even avoid chemotherapy. And there's a lot of data coming up in a randomized fashion, published in NEGM last year. So there's a lot of focus on it. There are issues with cost and toxicity. That is, that's also very important. But as a proof of principle, this is what the molecular analysis of these gliomas have translated into meaningful clinical practice change. And the questions are length of duration, financial burden, and so on and so forth. Finally, 1 or 2 small cases, then you get this extremely difficult cases. This was an 18-year-old boy. Both the parents are doctors, actually, in Hyderabad, intensivist and pediatrician. And you can see this tumor, almost like a pilostic, but you think of a GBM as well. But 18-year-old GBM, largely cystic, but this enhancement is not very good. There's a bit of edema. Actually, I spoke with Vani. It was called high-grade glioma. We treated actually with focal proton with temozolomide, but something was wrong because they had oligo. So we sent for DNA methylation to Germany, and it turned out to be FOXR2 activated neuroblastoma, which is actually an embryonal tumor. And this has been recently included. So this gets bizarre, rare cases. Now we have actually seen 3 cases such that they have actually, now you see the prognosis. The GBM prognosis is terrible. All of us know the parents were extremely unhappy, naturally, very concerned and anxious. But FOX2 activated neuroblastoma, in spite of being a PNET, has 75% 5-year survival, from 5% to 75%. So this is what, if you have that mind and you think which cases to do, what molecular markers, and you have a multidisciplinary tumor board, something unusual, don't go to the depth, you can make a remarkable difference in the patient's outcome. And pediatric high-grade gliomas also. Now, lastly, I want to discuss this point, which is just unbelievable. And this has caught our attention in the last 6 months to 8 months. We are seeing this increasingly, and now we have 8 patients like that, especially young patients between 55 to 50. And just an example, almost like a gliomatosis, you can see all over the tumor, all over the place. It was only a biopsy. Multiple hyperintense lesions. It was a co-sanguineous marriage child, what we call congenital mismatch repair deficiency gene. We have a genetist on our board. We did an extensive molecular analysis, both astrocytoma and IDH mutant. And these are immunotherapy overall has completely failed in GBM and gliomas. This was called GBM. But because of the MMRD, they are excellent candidates for immunotherapy. And this patient had an unbelievable response to both first proton we gave as an adjuvant, but then look at the checkpoint inhibitors, and she continues to do well more than a year now on immunotherapy. So there's a tiny percentage of patients who may benefit, but you have to have that mind to think along those lines, and that can also help as well. And that brings me to the point of the ISNO. We have published few guidelines already on it. Most of the markers are available, but there are diverse healthcare structures. It's very difficult to do it. We don't know which test to do when. There is no cooperation between the pathologist and the neurosurgeons and the oncologist. And therefore, there's a lot of issue. I do want to spend about half a minute on this slide because I see most of the people are blaming the cost, and I completely disagree with that. A simple MRI costs about 5,000 to 15,000 rupees or 20,000 rupees. Surgery costs so much, radiation costs so much, temozolomide costs so much, but we are always thinking only about the diagnostic IHC and small molecular markers. IDH panel, BRA, B600D costs only about 6,000 rupees. FISH costs 8,000 to 15,000. Even if you do DNA sequencing and MHT methylation, only about 7,000 rupees. The NGS is expensive. It used to be 4 to 5 lakhs, next generation sequencing, but we can do NGS as low as 15,000 to about 50 to 60,000 rupees. But look at the enormous difference that can make. 1 or 2 cycles or even surgical or neuro navigation, all that can actually cost as much. So therefore, we have to keep our mind open in this situation. So the Asia Oceania Society, and Chitra Sarkar is actually the president these days, along with her colleagues, and I'm helping them in the Neuro-Oncology Advisory Board. They have done tremendous amount of work, and you can see one paper is already in press at the moment. It's called Adapter Guidelines. These are the Asia Oceania guidelines. And David Lewis, who actually gave the WHO CNS5, he is also advisor. And there'll be series of 2 or 3 articles by the Asia Oceania group, which is going to make it crystallize and make it relatively simple and easy to follow with financial and which company to go to, which are the cases to be discussed in MTT such that you can do proper care. So in summary, I would say development in 2016 has been useful. We may have a nihilistic and negative approach to it, but it's here to stay. So you might as well embrace it as much as you can. It has been well realized in many parts of the world. It has sensitized the community. I gave you 3 or 4 examples, brought them together. The diffuse gliomas, pediatric gliomas, the whole lecture I can give on medulloblastoma, maybe some other time, because that's a complete game changer for molecular analysis, are much better managed in current practice. And therefore, many of us believe that CNS 521 is a natural evolution. We are already starting on 2024 update now. At the same time, however, I must admit that the pace of development is frenetic, definitely intimidating to surgeons, clinicians, pathologists, advocates, healthcare planners. Incorporation of entities integrating relevant practical guidelines has to be done very judiciously, very thoughtfully, looking at the dynamics and social strata as to how we work. But it is here to stay. I strongly recommend that there is more judicious integration, and I'm glad that this has been chosen for today's webinar. But I do believe that Asia Oceania is actually doing a remarkable work, better than actually even WHO. And the guidelines and recommendations are work in progress and may address the need to some extent. I hope I have been giving you some flavor of the rather difficult topic, and I'm happy to take any questions. I thank you very much again for your attention and this kind invitation. Thank you.
Thank you, sir. Excellent talk. And definitely we are having some questions, but that we will take after the third talk. Thank
Sir,
you.
I think Taggi sir is not there. He has not joined.
Okay.
Sir, we can open the discussion.
Yep, definitely, sir. So I would like to have some comment from your old colleague and your senior, Dr. Atul Goyal, sir. The scenario has changed. We have learned a lot from you about operating the glioma and how to operate and when to operate, how much we should go ahead, looking at this molecular biology and the further futuristic aspects of this molecular biology. So what your opinion about it, sir?
No, we heard some fantastic lecture, particularly from Dr. Rakesh Jalali. And if you see, he touched on basics. He touched on basics of molecular pathology, neuropathology, histopathology, and basics of treatment, and went on to dealing with immunotherapy kind of thing. So from basics to most advanced kind of treatment, he has touched upon. As far as as far as the neurosurgery audience is concerned, I have to say that as long as the neurosurgeon thinks that the knife is safe, as long as the neurosurgeon thinks that he can remove the tumor to the extent that safety is not compromised, and if he is confident to remove the tumor by surgery, he should do surgery. And then we have to wait with folded hands for tumor to recur. And if it recurs, even then the surgery, if it is to be done, surgery has to be done. This is true for basically tumors like meningiomas. However, gliomas and other tumors, as Dr. Rakesh Jalali mentioned, there is tremendous things going on in the field of adjuvant treatment, and Dr. Jalali is leading this proton unit in Apollo Hospital in Chennai. And I'm very happy to see him. He has worked with me for at least 30 years in TMH when he was here in Mumbai. And we had great companionship. It is always a pleasure to hear your lecture, Rakesh.
Thank
As
you.
far as Rakesh, I was, whatever you said is from basic to the most complex issues you have discussed, from cost factor to various kinds of things. It is only a person like you who can incorporate everything of this kind for an audience that is not very specialized in each of these entities that you have discussed, like immunotherapy, like molecular biology, like advances in histological advances, like in WHO kind of classifications. You have incorporated the entire gamut and simplified and presented. I think quite a wonderful, and we should keep this presentation for our future reference. And whenever we are in we want to know, we should be able to get this talk back and listen to what Dr. Jalali has said.
Patkar sir, any comment?
Yeah, in fact, I was very happy to kind of get updated where the radiotherapy is concerned, especially the first speaker who talked about the use of romancin in tumors which are close to the limbic system. I would be really interested in not how many of us really look into cognition before referring the patient for radiation or before surgery. What has been the experience of others regarding a cognitive analysis and outcomes after surgery or after radiation? So if the first speaker is there, I would like to ask him whether they do cognitive analysis before subjecting the patient to targeted radiotherapy.
Yes, sir. Actually, in TMH, we have long-term data. We have done the patients the pre-radio surgery, pre-radiation IQ analysis with multiple variables, and even follow-up for 5 years for the benign and low-grade brain tumors. And we have definitely as long-term data, which is published, I think, the 2 years back in the Journal of Neurosurgery. And the Dr. Jalali was the guide that time.
My question is whether it is now a standard for all patients to come for radiation.
Ideally, it should be standard. It is very subject person to person because they should have the neuropsychologist to do the all assessment and all scores to do all these things. Ideally, it should be the standard, but it is not followed everywhere because it requires the multiple peoples for the assessment tools.
Because what I had encountered in literature is that if the cognitive analysis is poor, then it is better to explain to the patient as it is the survival is not going to be very fruitful. If cognition is poor, then whether it is worthwhile going ahead with radiation.
So that is the guidelines clearly says because now based on the availability of systemic therapies, we have seen the long-term survival with the patients. So the cognitive function is really matters in a patients who have a long-term survival. In that cases only you are going to do the hippocampal avoidance, memantine, or the radiosurgery or the surgery itself. So the cognitive function matters in the patients who have the long-term survival, or we're expecting the long-term survival based on the biology of the tumor.
Dr. Giri, what is your opinion? Do you do cognitive analysis of all patients who are subjected to glamour surgery?
Sir, routinely we are not performing it. Basically, maybe we are a little bit reluctant, but definitely what he is saying, what the protocols they have been followed at Tata, and the neurocognitive is a major factor, sir, in all these glioma patients. You see, lot many patients we do operate, we give radiotherapy, but definitely we lack in the facility of that getting the neurocognition done before and after the radiotherapy. So ideally speaking, this is one of the takeaway message that we should go for all these things. Chaudhary sir, Kishore Chaudhary sir.
Well, sure. I'm a bit fortunate. I'm a bit fortunate because whatever you're saying that we should have, we happen to have in our center. we have about 60 tumor patients referred to us every week. And our multidisciplinary team involves at least one neuropathologist, at least two neuro-oncologists, at least two neuroradiologists, and at least four neurosurgeons, in addition to a neuropsychologist and neuro-oncology nurses. So unless this quorum is there, we will not conduct our MDT, which is a weekly event that takes at least 4 hours every Wednesday. And we do have input from a clinical psychologist. We do not have resources to do cognitive evaluation pre and post radiotherapy in every patient because of the volume that we have and shortage of staff. But I think that is something that is always at the back of our mind. I have one comment about the radiosurgery. Sheffield has been the national center for radiosurgery in the UK, apart from London, for last 40 years. And we've got a huge volume of patients as well for radiosurgery. And we do see that our four radiosurgeons would offer radiosurgical treatment to patients with metastases as long as they're less than 20. And as long as they're less than 3 centimeters. Occasionally, if it's more than 3 centimeters, we would consider surgery or fractionated radiosurgery. But our results seems to be quite promising. I don't have the data in front of me right now. But the more I look at it, I've been in neurosurgery for 30 years now in UK. The more I think of it, I'm more and more convinced that for glioblastomas or high-grade tumors, I think what surgery can achieve is going to be much more limited by what the newer advances are there in the investigation and the treatment modalities. So surgeons will be the first line of treatment, but we will never be the curators of these lesions. I think the more and more I can see the advances here, I think we will probably take a backseat. And that will be a dream day for me, where there will be a drug developed by clinical scientists like Dr. Rakesh Jalali and his juniors anywhere in the world, where we give just chemotherapy for glioblastoma after biopsy, and that will be curative. Well, that is my hope. Until then, I think surgery will remain a mainstay for this tumor. And another thing that I noticed that I don't know, our oncologist will not accept a referral to them after surgery unless there's an immediate post-op scan. Our protocol is surgery followed by MRI scan with contrast within 24 hours or at least 48 hours after surgery. If that is not done, our oncologists are very unhappy. And we cannot let our oncologists be unhappy because they are the one who are the mainstay of the treatment, not surgeons. I don't know what Rakesh.
Kishore, here in India, we do the contrast scan before starting any kind of adjuvant treatment. So it is just there's no question whether it should be done immediate post-op or whether it should be done before starting the radiation or chemotherapy. I'm sure all centers will offer adjuvant therapy, do a contrast scan before planning what kind of treatment they're going to give.
Sure, sir.
I think we are
48 hours. Any specific?
I think we are talking to different things, Sushil. All I'm saying is post-op scan to justify that the tumor has been gross totally macroscopically removed, if that's what the surgeon says. And the treatment, the MRI scan before adjuvant treatment would be a baseline scan before the adjuvant treatment begins. But that could be different from the post-op scan that is immediate post-op. And I find that wanting. We surgeons, we always overestimate how much tumors we have removed. We say that we have removed the tumors completely. We don't do post-op MRI scan immediately. And if the tumor comes back in 3 months, we label it as a recurrence when it is often a regrowth of the residual tumor. So I think there is a bit of problem in what we say and what we do. So when we say that I have removed the tumor gross macroscopically to the patient, that is a half a sentence. I say gross macroscopic removal of the tumor as proven by a post-op scan within 24 hours of surgery. And if that is not done, I won't be allowed to do surgery here.
Sir,
I don't know if you're dealing with the glioblastoma in India. The first priority, and we do frozen on table. What the first priority is to get out safely from there without giving rise to new deficits, rather than struggling to follow every tumor bit. I want to hear Professor Goel's opinion. Dr. Goel, do you think that a immediate post-op scan is important when you know that it's a glioblastoma? Where is Professor Goel?
Dr. Patkar, can I make a comment?
yeah, definitely, sir. Jalali, sir, please, because this discussion should be towards the molecular aspect and the radiotherapy. Surgical
Sorry,
aspect,
yes.
we generally talk a lot about surgical aspect. So please.
But I'll just briefly.
That's true.
Yeah, I mean, Dr. Chaudhary, first of all, it's a pleasure to see you again, even if it is virtually. And I remember our Mumbai days. So, but what you made absolutely correct points, and I'll just briefly touch upon all the 3 points that you mentioned. First of all, MDT is critical. In our center, both in TMH, we started 2003. And now in Chennai, we do 2 MDTs Tuesday and Friday of 25 cases each for 2 to 3 hours. Among the people that you mentioned, we all have on board, but we have two more people actually. We have a genetic counselor and genetist now on board in neuro team. And we also have a molecular biologist on. She doesn't come, but she's anytime on a phone call away because she has to give the inputs. And imaging, of course, is very important. So that is critical. That is absolutely no doubt. This has become more and more, I must say, in India. I mean, India, as you know, is very diverse and so heterogeneous. But many centers are adopting some form of MDT. May not be as vibrant and robust as you mentioned, but it is there. It is getting better. Neurocognition is a touchy subject. I led the neurocognition trials, series of trials in TMH. We used to do every single child. In Chennai, every single patient before treatment does get a detailed neurocognitive, not so much in adults as we do it in children. So that is incorporated, not only the neurocog, but the quality of life as well as neuroendocrine. We have a pediatric endocrinologist, an adult endocrinologist, a neuropsychologist, and a neuroophthalmologist as a part of the team as well. But this is a rare situation. This is not the mainstream India. As far as the post-op scan is concerned, I mean, the standard of care is to do a post-op scan immediately. In many parts of Mumbai, including Dr. Goel, by the way, we used to do within 24 to 48 hours in many instances. And in Apollo, of course, we do always. Although Dr. Patkar is also right in many cases because there is a limited amount of MRI, the resource allocation is very important. You perhaps may not need to do in a 70-year-old GBM or a very simple butterfly glioma or a corpus callosum or an allocan cortex, but in a younger person, in a grade 2 astrocytoma, sometimes in oligo, and most importantly, I would say in ependymomas and medulloblastomas, we always should do a post-op scan within 24 hours because the surgery is so important, especially ependymomas. 20% of our patients, when they come for proton, they undergo resurgery. And we have a fantastic neurosurgical team, initially by Dr. Rupesh, now with Dr. Ari Chako, and 4 of his members who do. And Rupesh also, because everyone doesn't have an intraoperative MRI, we do what is called extraoperative or perioperative MRI. So while the sutures are not removed, and at least 10 to 15% of the patients, they go in again and many a times. And we get fair amount of recurrent cases because recurrent post-RT, post-op cases little hard to discern between the normal gliosis, the other recurrent, as well as the treatment change. And many a times it helps. So again, as a whole country, I would say only about 10 to 15% do it as a whole country. But in many isolated areas, it is done routinely, but judiciously choosing who are the patients. I don't think we should do 100 and 0. In a country like India, as compared to other countries, you have to judiciously utilize your resources. And in many neurosurgical and neuro-oncology setup, gladly have to say that it is getting better and better.
Every time meeting, I get this impression that it's time for me to stop.
I have a question for Rakesh, for yourself.
Yes.
You know, the 2016 classification and now 2021 classification, has it really made a difference as far as management is concerned? I'm not asking cynically, I'm just inquiring whether, because we as neurosurgeons everything simple. And the more complicated the classification has become, it becomes really confusing for people like us who have very little day-to-day knowledge of oncology, classification, as well as the newer treatments.
I think it has made a big difference in my opinion. In fact, 21 classification has made 2016 simpler. The diffuse gliomas are only 3 or 4 types now. You don't have to break your head in hundreds of other tumors. They have removed also a lot of tumors. The pediatric neuro-oncology has become more tough and more difficult, and that is because of NGS. I didn't touch too much about it because I didn't want to make it too complicated. Now, every single pediatric glioma, at least in our setup, we perform NGS and we do fusions, and I'm sure you do it in UK as well. So you see whether it is EGFR driven, whether it is BRAF driven, MAP kinase driven, whether it is PDGFR driven, the diffuse hemispheric glioma, for example, HG34, which is actually ATRX loss, very interesting, oligo-negative ATRX loss, and MGMT methylated in 60% of the patients. So, and their outlook is different than GBMs, and there is a targeted therapy PDGFR inhibitor, dasatinib, which is now making some waves in that tumor as well. So, as you rightly said, ultimately it's biology, but biology is not like surgery or radiation, it will happen in one day. It is a continuous spectrum. We literally build brick by brick the blocks, and the 21 is a natural evolution of what we discussed in 2016. The adjuvant therapy in adult diffuse gliomas has not changed so much from 16 to 21, I agree, except it has made it easier. And as you know, the IDH mutant grade 4 is a big thing as compared to GBM. And I just showed you the exciting molecule against IDH mutation, the vorasidenib, and maybe it will have some impact in future as well. So that is number one. The medulloblastoma has become beautifully crystallized, as all of us know. The Wnt pathway, the management is quite different now than as sonic hedgehog and group 3 and group 4 in the adjuvant setting, even from the surgical point of view, although, by the way, group 4 medulloblastoma, the NTR is significantly better. While in Wnt pathway, if you have a radiogenomic data, and especially going towards the Lushka and CP angle, you may actually leave a little bit tumor behind because the cure is 95 to 100%. So there are practical implications of 2021 classification in your routine clinical practice. And I can talk about ependymomas. I can even talk about pylostics. We tend to think pylostic is a very simple tumor, but actually all of us know it is not a simple tumor depending upon the location. Chiasmatic gliomas, the deep-seated, the thalamus, the cervicomedullary, the pontine, they all exhibit different kind of mutational profile and long-term outcomes. So in summary, I would say the correlation is becoming better. 2016 was overwhelming. 21 is the step in the right direction. I think 24, 25 will be even more kind of slimmer and slightly better easily. And by the time we will learn also, the only challenge I have is DNA methylation, which the West is trying to force upon our throats. I'm not convinced DNA methylation is the right way to go for every single tumor, but hopefully the next 3-4 years we'll learn something about that as well.
Sir, we have two questions in chat section.
Yes,
The
please.
first question is whether from Rishita, IDH inhibitors are used in low-grade gliomas or high-grade gliomas. And second question is from Dr. Pratima, which all new targeted drugs are available in India, which will make the difference in management?
Excellent. Very good questions. Thank you very much for asking. First of all, IDH inhibitor has taken the world by storm, at least in our neuro-oncology circles, because as I mentioned, it's a proof of principle that there's a drug now against the basic gliomagenesis driver mutation. The trial so far, the evidence is for low-grade gliomas, not for high-grade, who have IDH mutations. So only for grade 2 tumors, small tumors, which we were tending to observe sometimes, all of us observe, small insural gliomas, which sometimes have been operated. The tumor is only about a centimeter or 2 centimeter. Some of the people were not very happy with observation. So they randomized patients with observation versus this drug. And there was an improvement in progression-free survival when they used the drug. So therefore, it shows that the drug does work against IDH mutation. To many of us, however, the main impact, as was the implication of the question, would be in high grade, because low grade, anyway, they do well, relatively well, especially oligos I mentioned, but also astrocytomas. The RTOG 9802 study also incorporated radiation plus temozolomide. We rarely ever actually observe patients now, especially more than 40 to 50 years of age. If they have a large residual crossing the midline, all those factors are already present. And lastly, I want to tell you, and it has a relevance for Dr. Chaudhry's question also, And all of you know, Dr. Patkar, all your senior people, some of the grade 2 tumors also don't do well. They can be IDH mutant also, or even grade 3 astros. Within 6 months to a year, in spite of giving radiation also, they come back. Some of the patients you must have seen, almost like a glioblastoma. And you wonder what is happening in those patients. So now it has been demonstrated 5% of grade 2 IDH mutant astrocytomas and about 10 to 15% of IDH mutant histologically confirmed grade 2, grade 3 astrocytomas, no evidence of grade 4. And about 30% of IDH mutant grade 4 astrocytomas have a unique molecular mutation. It's called CDKNA2B deletion. Again, very complicated, but we have been using it for the last 2 years. And if they have a CDKNA2B co-deletion, they are called molecularly defined glioblastoma. They are terrible tumors. They recur very fast, typically in young people, 30s and 40s. And those are the patients who don't do well, and you get surprised what happened in this patient. Now, there is a big emphasis, can we find a target against CDKN2B? This drug, IDH mutant, and there are 1 or 2 drugs in the pipeline, there are about 5 IDH inhibitors. It's done by a French company called Servier, although the trial was led by the Americans. And they are working on some therapeutic targets, even in high-grade IDH mutant tumors. And the next 5 years, watch out for space. Hopefully, there'll be something else. So that addresses the first question, that how do you use IDH inhibitors? The second question is which targeted therapy? So I would say 3 or 4 targeted therapies. Number 1, I mentioned, is BRAF V600E mutations, very fairly commonly given in melanomas and other cancers. So we use it for BRAF V600E mutation tumors. And these are the tumors, which one? Pleomorphic xanthiocytomas, especially if they are grade 3 or they recur after surgery and radiation. Epithelioid glioblastoma, about 5 to 7% of these GBMs. Young people, cortical location, bleed. I mentioned, I showed you one case. We have there's a paper in press at the moment, which is a series of 15 patients of epithelioid GBMs. You will hopefully see it soon from our group. And so there you use the IDH the BRAF inhibitor called dafrabenib. There is a MEK inhibitor which uses MAP kinase, which is typically used for pilostic astrocytomas. Those pilostic optic chiasmatic hypothalamic gliomas, which you take only a biopsy, the child is less than 5 to 6 year old, and you don't want to subject them for radiation. Even proton, sometimes we hesitate because of the side effects. Again, neurocognition, the endocrine damage, the pituitary hypothalamic axis, the brainstem necrosis, sometimes with radiation, or especially also in neurocognitive failure of not only hippocampus, but frontal lobe, fornix, amygdala, the whole circuit, what is called now neurocognitive connectome, is being identified as to what are the neural structures which are responsible for neurocognition depending upon age. So that can be all avoided with radiation. And then therefore the targeted therapies, if they have BRAF fusion, 60 to 80% of pilostic astrocytomas will have BRAF fusion, not mutation. Fusion is slightly more expensive. You give them targeted therapy of trametinib, which is available in our country now for the last 1 year. And that has shown significantly better survival as compared to conventional chemotherapy with lesser toxicity. And that paper was published last year in the New England Journal of Medicine. Eric Buffet is the first author. So that is available. The third drug, which kind of is used quite extensively, sometimes abused also, is Avastin or bevacizumab, which is a targeted therapy against VEGF inhibitor, which we use extensively in recurrent GBMs and sometimes also in post-radiation or post-radiation necrosis and treatment sequelae, which is not uncommon, by the way, in gliomas. Frequently we see in our practice. And it is a very good drug. It's like a super steroid, reduces the inflammation, reduces the edema, normalizes the angiogenesis. It is not curative though, but it gives very good extended progression-free survival and quality of life in some patients. So these 4 or 5 drugs are readily available in our country. But and there are others. I don't want to go into detail. If somebody has an anti-RK fusion, a rare pediatric patient, then that's a lorlatinib. And there are erlotinib, and there is osimertinib if they have EGFR mutation across the blood-brain barrier. So there are 5 or 6 more drugs available, but largely the 4 drugs which I mentioned you early, these are the ones which are readily available, and judiciously, if you use them, can make a big difference in the outcome of the patients.
Thank you, sir. I really appreciate the presence of our webinar committee members, Dr. Mujumdar sir, Dr. Milind Dunate, Dr. Abhay Kumara, Dr. Ranjit Deshmukh. Please, anyone have any question can ask Dr. Jalali?
Yes, I have a question. Can you hear me, Prabhu?
Yeah, yes, sir.
I have a question. Yeah. Uh, I want to address this question to Dr. Jalali.
Sir.
Fantastic lecture. Very happy you simplified it and you gave a sort of scope of all the markers. I have a couple of questions for you. One is that oh, we see a lot of people with post-radiation changes, sometimes with the advent of use of temozolomide, also pseudo-progression, and it is very difficult to differentiate it from true progression at times. So what is your strategy for differentiating it is one. Second is how many times do you use Avastin? And third, if the changes come after a couple of years or say after 18 months, what is your take on giving proton in these patients?
Okay, very good questions. I'll try to answer them very quickly. First of all, it is fairly common to see pseudoprogression. Pseudoprogression typically within the 3 to 6 months, more common in MGMT methylated patients, more common in IDH mutant grade 2, grade 3, especially if you give slightly higher doses. Nowadays, we have tried to optimize the doses that we don't see so much, but still we see quite a bit. And it's sometimes very hard to differentiate between a recurrent tumor. However, we have basically banked on a high quality MRI scan. A baseline scan is important post radiation after 1 month, and then you do, on 3 months, or if the patient becomes symptomatic. And typically they are hypoperfused. Perfusion is very important, but you have to have a baseline also. So typically they do not show any perfusion. Even if perfusion is there, perfusion is done by three things. One is called RCBV, which is very, very simple. It is relatively cerebral blood volume. The volume, which is the blood volume, which is going per 100 grams of normal brain tissue, and you compare it with the opposite side, the contralateral side, whether it is frontal, parietal, temporal, occipital, or whatever it may be there. You put an ROI there on the system, and all the MRI scanners have now perfusion, but you need to give contrast very fast in them within 120 to 125 seconds, and then you can get very good. It's called T2 susceptibility. You actually look at the loss of contrast. It's called T2 susceptibility imaging, and that if the perfusion is not very high, hypoperfused, then it is more towards treatment-related change. But if it is hyperperfused, that's 3 times more or 4 times more or 5 times more, you tend to have more tumor. So that is number one. Number two is sometimes what happens is there's a blood vessel or near the bone, you cannot put contrast. So there is a beautiful technique called ASL. Again, talk to your radiologist, they will do. It's called arterial spin labeling. Basically came from stroke. That shows CBF, cerebral blood flow, not the volume. So you have to combine the CBV and CBF. If you have CBF, the great advantage of ASL is you don't need contrast. You can get the ASL. And the latest is called APT, amine peptide transfer. It's only available in Philips machine, but other machines, GE and Siemens, are also trying to incorporate in their own way. So a combination of perfusion, but also small other pointers. Most of the recurrences are cortical. If you see periventricular towards the inside of the brain, they invariably are treatment-related changes. Don't bother too much about the tumor there. Also, how symptomatic the patient is. Also, sometimes if there is a kind of an equipoise, you don't quite know, you just follow the patients up, repeat the MRI after a few months or few weeks, give some steroids. And then you will, most of the times, I would say in our practice now in 5-7 years, 9 out of 10 times we are able to crack whether it is a pseudo progression, treatment change, or is it really a tumor recurrence. Although sometimes there can be a mixture of the two. Last week, Dr. Chaco operated upon one of my patients with GBM. There was 30 to 40%. I always ask neuropathologists, how much is the component of radiation treatment related necrosis? How much is the viable tumor, which is recurrent? And how much is the quiescent tumor, which was always there? There's always some residual tumor along the sleeves of the operative bed cavity. And that will determine as to the further, whether you have to give re-radiation, retreatment, and so on and so forth. Avastin, I use quite extensively, typically 3 to 4 patients literally every week. We started Avastin in 2009. I kind of started it in a way. And that time we used to import. Now there are 8 to 10 Indian companies, much cheaper. There are many doses. We typically give 7.5 milligram for treatment-related necrosis per kg every 2 to 3 weeks. Within 3 cycles, 70 to 80% show exquisite response. The enhancement goes down, the edema goes down, patients are better. It's almost like a wonder drug. And my neurosurgical people tell me what amazing. Sometimes you tend to think whether you have to operate or not. It's a good non-operative strategy and fairly non-toxic. Then how many cycles to give? 6 cycles or 12 cycles, or even beyond that, we give consolidation 6 weekly sometimes. That depends upon case to case. People try to use it upfront setting to improve the survival. Both the randomized trials failed miserably. So we don't use in the right at the beginning. You should probably not use it along with radiation because it lowers the effect of radiation, because it puts a lid on the angiogenesis, which is very important for the radiation effect. But if you use case to case basis judiciously, in a very nice kind of a weapon, it can really help you in your practice. Lastly, we used to give 2 years time for re-radiation, but nowadays it's about a year, 18 months or so. For ependymomas for young children, sometimes it is even lesser. Also brings me to the point that 3-year cutoff no longer exists anymore. The ependymoma, posterior fossa A ependymomas, we treat patients as low as 12 months. The youngest we have treated is 9.5 months actually. And for medulloblastomas, for ATRT, for ETMR, for embryonal tumors, you can also treat less than 3 years of age, especially if you have high technology like a high-end IMRT. And of course, if you have proton, that makes it even better. So the age limit also is becoming a lower. That's also very important because of the new technologies. Dr. Desh.
Thank you. Most of my, we have, yeah. Am I audible? Yeah.
Last question.
So you have answered most of the questions, and we use all these MRI techniques, but there is still a small subset of patients where it is really difficult to differentiate radiation necrosis and true recurrence. And sometimes there is a place for biopsy, as you mentioned in your thing. Now, one more thing that I was one more comment was that about the grade 2 or the diffuse astrocytomas or the grade 2 2016, which behave badly. So we have been doing these molecular markers extensively, and as you correctly said, histone markers do come positive, and then we are at a loss, and we see a terrible flare-up of the disease within even 6 months.
Yes.
So what is the strategy for those kind of tumors?
We are struggling with those tumors.
The CDK.
Yeah, the CDKN2 and B are terrible tumors. I have struggled with it. All of us are struggling with it. There is a targeted therapy.
I mean, we got reports like
So
DIPG-like tumors sometimes.
The DIPG is a different ballgame. We can talk about DIPG separately. DIPG is driven by histone, the H3K27M mutation. They can have EZIP also. And if they are in the hemispheric, what is called diffuse hemispheric gliomas or G34, they have a histone G34, not the H3K27M. There are 2 or 3 targeted therapies even for DIPGs. We tend to always obtain a tissue as much as possible. About 7 to 8 out of 10 children, we managed to get a biopsy in my setup. Fortunately, with either stereotactically, you do the DTI, all of us, you do it and try to obtain a small biopsy, especially if they have a small exophytic component. For older patients, always, for even children sometimes, unless it is really in a poor KPS and classic DIPG. And ONC201 is the targeted therapy, which is not available in India as yet, but I have about 45 patients. We get the drug from Germany. And it has not shown outstanding results, but at least the clinical trials are out there to show some difference. And there is now an ONC206 trial being launched as well. But coming back to your original question of CDKN2 and B, and sometimes adult histone, they are also terrible tumors. Histone, EGFR, if they have mutation, if they are IDH wild type, they are called molecularly defined, and they have to have chromosome 17 also nowadays as per the WHO 2021 classification, which most of us don't do it. They are terrible tumors, even if they are histologically grade 2 or grade 3, an IDH mutation. So, but I do think there's a lot of research happening. Maybe we will stumble upon something, even vorasidenib, the IDH mutant inhibitor. We need to know how to use them. There is a proposal to use them with immunotherapy markers, as because some of them have instability of the microsatellite instability we call it on the genome, because CDKN2 make IDH can be a driver mutation, but the CDKN2 may make it unstable. That's why they are so aggressive. But if they have high tumor mutation burden, they have some MSI exhibition with PDL1, with or without PDL1, you could use neoadjuvant immune therapy markers like nivolumab and pembrolizumab and combined with vorasidenib in these difficult tumors. But these are all thoughts at the moment. Hopefully, in the next 3 to 4. Same thing we used to think 5 years ago of IDH inhibitor, but now the trial has come and EGM positive. 2, 3 years down the line, we may be starting using it also in routine clinical practice. Everything is a time of patience. Hopefully, something will come in CDK2 and B space as well.
And take the
Okay, one last
question
comment
from
I want to
Dr.
make. One last comment.
Yeah.
Can I make a last comment?
Dr. Deshmukh is waiting for a long time.
He's
Okay.
It's a question about CDK2. Are there guidelines about doing this test
Yes.
for all IDH mutant? It should be done, or only in certain cases?
I'll tell you. The guideline is we don't do it in IDH grade 2 because the yield is very low. It's only 3 to 5% unless it has a recurrence. You treat IDH mutant, either you observe or you give RT temozolomide or RT alone. After 3 to 5 years, it recurs, you operate, still comes grade 2 sometimes. Those are the cases you do CDK, or sometimes recurrence is early. So grade 2, we are not doing routinely. Grade 3, we are almost always doing routinely whenever there is a possibility, especially if there is a residual tumor. Sometimes the pathologist is not sure. There is a hint of microvascular proliferation. There's a hint of palisading necrosis, not enough to call it grade 4. So you still call it grade 3. All of us know that. Or operatively, you find frank necrosis. The pathology doesn't show. You believe it is grade 4, but actually comes out to be grade 3. So case to case basis, you can do in, it doesn't have any therapeutic implication, but you keep your mind open that this tumor is not going to do well and prognostically, because otherwise you'll say, don't worry, IDH mutant, everything will be fine for 5, 7 years, and 6 months down the line, the patient recurs. So it is a safeguard for all the neurosurgeons and neuro-oncologists for grade 3 tumors. And grade 4 also we do because 30% are CDK2 and B. Wherever it is feasible, you try to do it. It's a FISH test, costs a little bit more than IDH, about 8,000 to 10,000. And we don't do it routinely, but in selected cases, you should probably do it.
So we underwent similar situation recently. I had operated one large insular glioma last year. It was awake and I couldn't take it out completely. He had some speech issues. And then I observed him 2 scans, and then we decided to go in again rather than radiation. And this time our histopathologist was first time it was IDH mutant. So this time he said there are some changes. So the family went to Bombay, I think some private lab they did, and they again came back with IDH mutant and grade 2 and all. But he insisted, he's TMH trained. So he insisted and he sent it for CDKN2 and it came positive.
Yeah.
So, yeah, so that was the first instance I saw in like 1.5 years. The prognosis changed drastically.
You are absolutely right.
Karthikar sir.
Can I say something, Pramod?
Karthikar sir.
Dr.
Pramod, can I say something?
Hello.
Datta.
So
Yeah,
he
hello.
has radiation now,
Yes.
and he's on temozolomide. Do we suggest him something more than that? This patient or similar patients who are IDH mutant but CDKN2 positive. So we treat them as glioblastoma.
Well, if there is CDK, they should be like GBM. So we still unfortunately give them temozolomide because they're IDH mutant. You can give them a year of temozolomide rather than 6 months because that might help. But your threshold has to be low. There is a very high chance of progression rather early. But unfortunately, at this point of time, there is nothing extra we can do. So it is just something which is very difficult at the moment. Hopefully, in future something may come up.
Majumdar sir.
Hello. I think it has been a very great discussion, and I think the message is that what Dr. Jalali has said, that you have to be like a neurosurgeon scientist. We are all now getting more aware, and the first thing is that you have to have your own MDT. So I know many people are working in non-academic institutions or where it is not possible to do. But all these decisions are very crucial. What Dr. Jalali has very simplified it. Because a surgeon alone cannot do everything. So you have to identify a good team. And I have seen many people, sometimes they just send it to some lab. And what Dr. Jalali just mentioned about the cost. Now, sometimes the cost, the lab does the entire panel. And I've seen people, labs doing not IDH, ATRX, and 1P19Q, but running the entire glioma panel, and the patient pays about 50,000 rupees.
So
So that kind of overuse, abuse should not be done. So it comes all with a caveat that there are many, there it's very intricate and it is an evolving specialty. So my humble suggestion is that we have to be aware, we have to read, we have to go through all this consensus classification and have a good discussion in an MDT before, because that will help to give the appropriate treatment. So I think Dr. Jalali has done a fantastic job. Thanks. Thanks, Rakesh.
Thank you.
Article, sir.
Yeah, I think at the end of it, of an excellent discussion and very appropriately answered by Dr. Rakesh, sir, I think Dr. Pramod has time only to thank all the speakers and participants because we are running out of time. Thank you, Dr. Rakesh.
It's really a fantastic evening, and we have much enlightenment about the molecular aspects of the glioma. And definitely, it is Rakesh sir who has really consented and given excellent time and excellent, what you say, point out too many things about our management, routine management of the glioma. We all are happy that we are little bit more educated before this seminar, and definitely the senior people, they still insist on what we neurosurgeons do, that is a more taking out of the tumor, but there are too many things out of this only surgical aspect of the glioma pathology. Thank you, sir. I really thank all the senior and all the professors who have attended this seminar. We have excellent seminar, excellent attenders, and definitely the message will go on very far about the molecular aspects and their implications in the management of the glioma. Thank you, sir.
Thank you.
Thank you, sir. From MCNS, we thank you, Dr. Jalali, sir, and Dr. Vikas Kothari for their excellent presentation, and to all the faculties for bringing out the best discussion. Thank you, everyone. Good night.
Thank you. Good night, everyone. Thanks.
Thank you. Good night. Yeah.